you very much, and welcome to everyone. This is an unusual adjunct meeting. I think this is the first one we've had virtually. That's we have our development meeting, usually face to face in our classrooms with just a few groups calling in, and this time we're all on the screen and all virtual. And this has been the life that we've lived for the past 8 months. And it's a challenging, but also one of creative opportunities. And I would first like to take a moment to just say that I hope you've had some chances to learn some new things and some creative opportunity, and also to get a little bit more familiar with Zoom and all the terminology that goes along using it. I am still very challenged when someone says, please present from your screen in trying to find out where the file is and how to bring it up and all those kinds of things, but I'm getting better at it. Hope everybody else is doing the same. And at the same time, I'm also getting used to seeing myself on camera, which was a little bit of a shock. The first time I saw myself on camera, I've decided that the one thing I don't want to do is eat on camera, because that's not an attractive picture for myself. So, and I probably is not for anyone else. So that's another thing I've learned about being on Zoom. So, and the challenges continue. What I have also learned about virtual learning is that I'm much more organized, and I have to plan ahead, and there are no last minute kinds of things that go off much easier in the classroom when you're in person than when you are on Zoom and trying to conduct that. You really have to plan and think through what it is you want to present and how you want to present that. So for some of you, you are back in clinical courses with our students. Some of you are in skills lab. I'm just kind of interested in hearing from you how that's going. So please feel free after this meeting, since I can't interact with you personally because there's so many of you, to send me an email and tell me how you're doing in terms of the either going back into the clinical areas, going back into the skills lab, or teaching didactic online. And I'm also very interested in hearing any suggestions that you may have for how we can improve our services to you. Normally during our adjunct meetings, besides welcoming you to the meeting, I give you a little bit of an update on the School of Nursing. And I know Dr. Posa is going to give you a much more detailed review of how we have pivoted from face-to-face to online, and some of the challenges that and the new processes we've had to put in place as a result of COVID-19. The one thing that I think is really amazing to me is how wonderful you have been as our fellow faculty in terms of partnering with the School of Nursing and moving through this challenging time with our full-time faculty, with our staff, but most of all with our students. I can't tell you how much I've appreciated your willingness to put up with the mad scramble that resulted in terms of our initial changes, the flexibility you have exercised in terms of as we get our new processes in place and try to communicate that out. The overcoming the anxieties around going back face to face on things, and just being so courageous, I think, both as a nurse and as our fellow faculty in terms of supporting our students during these last 8 months. It's an incredible journey for them, and you've been there for them, listening to them, encouraging them, and helping them progress in their studies, because most of all, we would like these nurses to graduate on time and to pass the NCLEX, or to graduate on time and to become our advanced practitioners or our educators or our leaders, and to just contribute to healthcare at a time when it's so critical. I'm also very fortunate to introduce you to Ruth Mielke. Some of you may know her. So Ruth is one of our former alumni. She graduated from our doctoral program, and she's been teaching at Fullerton for many years. She's a nurse midwife as well as our new associate dean, and her responsibility is faculty development, alumni relations, continued education. I think I'm at least leaving out a couple of things, Ruth, but you could add that in. We've been orienting her virtually, which has also been a challenge, but we are actually now starting to, at least we did this last couple of months, starting to briefly move some of our faculty back on campus. I'm not sure if we're going to be able to continue that, but I am hopeful that even with this increase in incidence of COVID infections, we may be able to manage that and still come back to some degree of face-to-face interactions over the next several months and into the spring semester. The university is delaying a little bit in terms of making the announcement. They were hoping for a more positive response as to whether they would go virtual in the spring semester. It does not look very promising right now, but by December 1st, which is by the end of next week and beginning the following week, we will definitely let you know if there is going to be continued or opportunities for students to come on campus. They are particularly interested in bringing students back into the science labs and into some of the areas where they need to use equipment that can't be done remotely. For the nursing program, all of our students are still considered essential workers, and so there's not a question of whether we come back face-to-face. We will come back face-to-face in clinical placements and in the skills labs, but most likely not in the didactic classroom settings. I know that you will enjoy hearing a little bit of how we've pivoted, and I would also like Ruth to share a little bit about herself. So Dr. Mielke, if you could continue as leader of this gathering and just take a few moments to tell us a little bit more about yourself so that all of our adjuncts get a chance to know you if they haven't met you already.
Well, thank you for that nice segue introduction. And I feel so blessed to be at Azusa Pacific University right now with you. And as Dr. Lesh mentioned, I come from public education, and that was really, God wanted me there. And I learned a lot being at a state-funded school. And as Dr. Lesh mentioned, I am clinically, I work as a nurse midwife. I'm also a women's health nurse practitioner. But, you know, foremost, I'm a believer like you all here. And I love, I've been talking a lot in my new faculty orientation group. We've talked a lot about the three-legged stool of academia: scholarship, service, and teaching. But we get to have a fourth leg at APU that's actually a huge leg, and that is faith integration. So that has been a really, really fun thing for me to be unabashedly, unapologetically Christian. And I hope that you, each one of you, realizes what an amazing gift that is, and also what an honor and also a responsibility as we move ahead. I'll close really quickly. I have, passion for all things women's health. I have done some work in rural health, which I really love and have a passion for. Hey, I love childbirth. What can I say? Got a lot of things to fix in that arena. But again, I feel very blessed to not only be here with you, but that we have access to technologies. Pretty cool that God is author of all things, right? So with that being said, I look forward to hearing from all of you. Adjuncts, you're going to be seeing me again. We're going to be trying to figure out the best ways for you to be very closely aligned with what we're doing, and we need to hear from you as well. That really informs what we're doing. So I'll talk a little bit about that later, but I want to get to our CEU presentation. And that being said, I'm going to say a quick prayer for everyone here. Let's just bow our heads where we are. Dear Father, we adore you. You are the creator of all things, and we praise you for that. We confess that we have done things today that we weren't proud of. Please forgive us of those things. We are thankful. We come into a time where, in particular, we are so thankful for the freedoms that we have and for the access to resources that we have. Finally, Lord, as supplication, I ask a special blessing for each one of these essential workers. We're essential to your kingdom, and we're essential to this crazy pandemic that we actually don't understand, but we know that you continue to be in charge. I ask again a blessing and praise. I offer a praise to all those who are involved in this meeting, to the VLE team, and those that are attending. Thank you, and look forward to your blessing over us now. In your name, amen.
Amen.
So I am going to allow Dr. Posa to give a little more focused message to you before her team starts.
Thanks, Ruth, and thanks, Aya, for the introduction. And most importantly, thanks to each of you that are joining us tonight and on this call. It's fun to see your names. Some of you I've had as students, some of you have been longtime adjuncts with us, and we've been colleagues. And most importantly, thanks so much for all the work that you're doing with the students, especially during this time. Your care and compassion for them and with them is what's keeping them going. And we know this is, nursing school is stressful in regular times, but it's just been compounded now with all of the challenges that many of them are managing, not only in their schooling, but with their home situations, kids, and in addition to the pandemic. So thank you for hanging in there with us and for being willing to relearn and look at new ways of doing things. We were actually in the process of looking at some of these virtual simulations and how that could be the part of the formula of the recipe that we then ultimately use to produce a great nursing graduate from APU, whether that's at the bachelor's level or at the graduate level. So tonight, it's going to be great for us to have the opportunity to share with you a little bit of some of the virtual simulation that we're doing. But before we start that, I just wanted to show you something that we messaged out for students today, because you may be getting lots of questions from students, and especially as we're looking at Thanksgiving break next week. We've had, I just wanted you to make sure that everyone is aware of some of the safety things that we're doing for our students, in case you have questions about how to resource them or where to direct them in certain things. So I'll quickly go through this, and then we'll turn it over to the team. So we created a 6-point checklist, and I'll just quickly go through this just to remind you. So all of our students at any level, we are requiring them to do some additional training. So that's both in knowing what the virus is and infection control, as well as donning and doffing of the PPE practice. So in addition to the regular training, they're also doing some extra training around that, trying to have them the best prepared they can to be entering into those clinical settings. They've also been asked to do additional paperwork. They fill out an attestation form at the beginning of the semester, each semester, with a symptom review and some key points, and then their message that they're supposed to be letting us know if there's any change in any of their symptoms. Clinicals are voluntary at this point, and so there is a release of liability form that students are signing. That release of liability is an annual form. So those of you that are going to be working with us in the spring, if the students have already signed it, they won't have to redo that. But the attestation form every semester they complete that. The My Cougar Health Symptom Check is a app that they can do, or they can do it on their computer. We're asking students, anyone that's in clinicals, so any kind of clinical activities, or if they're coming to participate in any of the skills labs, they should be performing a daily symptom check. And especially you want to make sure that they're doing it before they go to clinical and or come on campus for any of our labs. You could always ask them to show you through their app. They should have a green check and the ability to show you a negative status. So feel free as faculty, if you're working with students in clinical settings, that you can ask them to show that to you, that they should have completed that before coming. Number 3 then is we really are messaging to them around social distance. So one of the areas that you could help us with is students will do it while they're in the facilities and on the units or in our labs. And then they go out in the parking lot and they're congregating together either without masks or too close. So that's one area that we could use your help to remind students to continue to social distance, even in the parking lot, as well as on their lunch breaks. So we've had some students have to sit out because they took their mask off to eat and they were sitting side by side while they were eating. And that puts them at risk. The other area that we've had questions around is carpooling. So students can carpool if they're roommates. If they're living in the same household, that's okay for them to be carpooling. If they're not, we're really discouraging carpooling because another source of potential exposure there. Free PPE every semester. We have a pack, and in the spring we'll have a PPE pack for the graduate level students, which has a few more surgical masks, and also one for our pre-licensure students that will have a few more of the KN95s in there, face shield, gloves, all the things that they would need to keep them safe, both when they come on campus to participate in their lab experiences or they go to their clinical sites. And if they need additional resources around that, they certainly have the ability to message that out to us, as well as we are providing fit testing if they need fit testing for N95s. Number 5 then on here is asking them to report symptoms, and we've really partnered with our Student Health Center. The Student Health Center is staffed with a physician and nurse practitioners and PAs that are actually doing contact tracing for any of the students who report possible exposure and or symptoms. And so they're in alignment and collaboration with us in the School of Nursing. If you ever have any questions of what to do with a student, where to direct them, Student Health Center would be a good place to direct those people to, students to, as well as the SON Health email. And either one could get you the answers that you need around that. And then finally, we've had a few students wanting to be creative with their scrubs and not wearing the APU scrubs. So just remind them that they need to wear their APU badge. Even when they come on campus now, they're going to need to have their badge in a lanyard, as well as their APU approved scrubs for those clinical settings. So hopefully that gives you kind of an idea of what we're doing to work with students and appreciate your helping us answer their questions and reminding. We also will be messaging out a special email to them around holidays here and if they're traveling and seeing family and gatherings, because when they come back for clinical activities before the end of the year, we want to really ensure that we're not putting the facility at risk with our students. Any questions around that? All right, then I'm going to introduce the virtual learning experience. So we have moved to a model of thinking of not just direct patient care activities, but more of a holistic approach of what is experiential learning. And the team will talk to you a little bit about the model. We have moved into some virtual simulation. So we hope to eventually, maybe in the spring, it'll depend on the university and the numbers, be able to get some of the physical stimulation back in our labs. We're happy that our students are still able to participate in their skills labs and their health assessment labs at this point, but we're really, for our simulation, we're depending on virtual simulation. And so the team is prepared to show you the impact that it's making with students. And I recognize some of you here, I know are virtual faculty that are working in some of these products. So the leadership team is made up of Jenna Reyes. Jenna is faculty in the ELM program in San Diego and is a certified simulation faculty, and is very experienced in all things simulation and debriefing. And she's taken the lead on the iHuman product. And then we have Mario Macayón, and Mario is our simulation faculty, director of simulation, and also PhD student, getting close. And then we have Chris Racinos, who's a grad of our PhD program like Ruth. Chris is a new faculty member that's joined us this fall and is participating in with the virtual team. And then we have Lori Lang is our curriculum specialist within the School of Nursing. And so she's been helping with the case alignment and everything Canvas that supports some of the virtual learning. And then Vicki Bowden, and Vicki is faculty in the School of Nursing, and has been very helpful as we think through student evaluation in a virtual. So we know we're a practice performance-based profession, and how can we virtually do some of the evaluation methods with students that we need to do to make them practice ready for when they graduate. So I appreciate each member of the team and what they bring to best thinking as we move forward. So I'll turn it over to them for the presentation.
All right, welcome everybody. We are happy to have you here on this Wednesday, a week prior to the Wednesday before Thanksgiving. Why don't we go ahead and go to next slide. So our presentation today is going to be on virtual learning environments in the nursing education, pivoting during a pandemic. You will be able to receive one CE for this, for attending this presentation. Our objectives today, we are going to do two things. We're going to compare and contrast the learning theories that guide both iHuman and NAVIX and the virtual learning environments. And then we're going to talk about two preceptor strategies that could be used to augment clinical reasoning skills acquired by the students who are using the LE. So these are the Fantastic Six, I like to call them, in terms of the virtual learning. So we are led by our fearless leader, Renee Poza, and Renee introduced everybody else, but here are our glamour shots for Vicki, Lori, Mario, Jenna, and myself. Next slide. All right, so when we talk about experiential learning, virtual learning is a component of experiential learning. So the experiential learning, what we define that as is a combination of these four areas. So we have our direct patient care. So that's practice either in an ambulatory or inpatient or community setting. And so there's an instructor and a preceptor in that setting. It could also include additional clinical activities. The second is our health assessment laboratories. And so that's where we have traditional exam rooms, and staff and nursing students can go in and practice their assessment skills. And then we have our nursing skills laboratories where they can practice psychomotor skills. So think about IV insertion. The third piece of it is the simulation that is in the lab. So this is a sim lab, and that's where we have our high fidelity mannequins. There's other mechanisms in terms of technology that reproduce the actual care environment. And then there's the virtual learning experience. And so the virtual learning experience is an online platform where nursing students go in and actually take control of the clinical scenario as if they are the nurse, and it provides a variety of different scenarios and then ends in a debrief. Next slide. All right, so we're going to do a test, and it's not graded, so you're not going to get an A, B, or C, but we are going to put up on the poll these two following questions, and I'd love to get your feedback. So the first question is this true or false? Virtual learning experiences in nursing education have come about because of a reduction in clinical sites. Is that a true statement or is that a false statement? And I will let whoever's doing the poll put that question up for us.
So the polls aren't working because of the person who set up the Zoom. So we're doing it this way. So they're going to answer in the chat.
Awesome.
So
So put it in
just
the
answer
chat.
in the chat. Yeah. Then we have
you-
someone monitoring the chat, right?
I can see. So I see false, 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 false. I see some true, some false. For those of you who are putting false, why is it false? Let me see that in the chat too. What do you guys think? I'm seeing half true, half false. We were incorporating this anyway. Judith, that is correct. Why? Did we know because we were going to be losing clinical sites? It's evidence-based.
Vicki Young with the answer.
Yeah, so virtual learning experiences, let me ask you a question. How many students, let's say we have a group of 60 students, how many students do you think of those 60 will have an experience with a patient who is undergoing an active MI out of 60? False. How many do you think? 10 out of 60? Maybe if they're getting an ED rotation, right? Maybe. How many? Not very many though. It's not going to be all 60. It's 0. Yeah, Vicki, it's probably going to be a handful. Maybe like honestly, like under 5. How many do you think will actually be in the clinic or in the hospital when the patient goes from not being septic to becoming and then being septic?
Yes, Vian with the answer again. There we go, Vian.
Yeah, probably not many. And if they are with that patient that's septic, they're probably going to just be following the nurse. They're not going to be the ones that identify like, hey, wait a minute, this patient has these signs and symptoms. Hey, wait a minute, look at their lactic acid level. Like they're not going to be the ones really doing that. They're going to kind of be more following nurse. How many of you guys think the patients or the nursing students would see autonomic dysreflexia out of 60? 0, 0, 0. Yeah, but guess what? I was a chief nurse executive, and my expectation is when they graduate, they know how to take care of those patients. And so by introducing this virtual learning platform, we are leveling the playing field. We're letting these students be exposed to scenarios that they're definitely going to see when they go into the hospital. And they'll have experience thinking about the critical components around what might a nursing diagnosis be? What does education look like? So virtual learning, actually about 65 to 68% of nursing schools were using virtual learning prior to COVID. And so it's just somewhere that APU was going to go. We're finding in the literature that through virtual learning, those students that are getting that experience in their courses are passing the NCLEX at a higher rate. And we're finding that their sentinel events are significantly much more lower in a new grad period than those who have not had virtual learning. So virtual learning is not going away. We have students say, you know, my clinical allows me to do the extra 2 hours, why can't I? Because we want to make sure that you've had the ability to experience what everybody else should be experiencing to make you a safe nurse. So next question is, virtual learning experiences are useful for which of the following learners? It's great for our entry-level masters, our NP students, or it's really great for our traditional BSN students in their capstone. See, all of these. Oh, yeah, for sure. What do you guys think about virtual learning in the administration space? So we're getting ready to start a new health admin program. What do you guys think? Do you think that's something that would be beneficial for those students, or is it only really for students that are, you know, in clinical? Yes, important. Absolutely, right? Let's have that crucial conversation on a fake patient before we destroy one of our employees' lives. Yes. So it is all of these virtual learning experiences are really important and great applications for any type of learner. So, and that's nursing, inside of nursing and outside of nursing. So you can go to the next slide. You guys did great. Y'all got A's. So when we look at our competency-based experiential learning model, I talked about the 4 different components, and the way that each class is set up for the curriculum is that we will determine how many hours are going to be the patient care, how many will be in skills, how many will be in SIM, and how many will be in VLE. And so an example of a clinical course like URNS 402, we need to have 90 hours, and it will be a combination of each of these 4 areas that'll make up that 90 hours. Next slide. So what is virtual learning? So it's a variety of different modalities. So we're not using this here, but we see things like what you're seeing on the screen, which is utilizing a camera that can now look at the bone, right? I can touch the tendons and move them around and go deeper and look into the visceral organs. So there's that type of virtual learning. And then there's the types that we're using right now, which are really based on improving competency and critical thinking. So the two products that we're using at APU are iHuman and Navex. And we're going to go into depth around the two different products, the theory behind them, and how we chose to use them.
So, and Chris did a really good job of presenting and letting us know why we're doing virtual learning. It's not a replacement of our adjunct, it's of our clinical sites. It's an adjunct to our clinical sites. And we really talk about, we're really trying to and really improve the development of clinical reasoning way before they get close to NCLEX and have to be tested on it. So our goal is to graduate nurses, not only that pass their NCLEX, but then can go practice as safe nurses. So we're using our virtual learning in a way to address some of those cases that, like Chris was talking about, that they would never probably have an opportunity to see, you know, and they would, if they did see it as a new grad, they'd be like, I think I read something about that somewhere. Like they wouldn't know, oh yeah, I remember this because I had a case. And it really gives them independence because they are working through the case independently on their own computer at home, and then working with faculty and the team to really develop their clinical reasoning. This is just a quick review of literature and why it's important, because it goes to the theory and the background of why we do VLE. Why is it important? Why is it appropriate? You know, we as educators, we're aware that we're trying to develop clinical reasoning, critical thinking skills, clinical reasoning, but it's really hard to narrow that down because we don't have a good definition. I reviewed like 78 articles and not one had the same like definition. APA has a definition, but not everybody uses that definition. So what we're trying to really create is something that's really challenging for all of us as educators. So we test this in our NCLEX exam. We all know that that's a test for clinical reasoning. Can they apply the knowledge that they've learned in education to be a safe nurse, right? And some of that problem is that we have a theory practice gap, and this is a big part of VLE. You as a clinical professor cannot be in the room with every student at all moments of time. So you're not able to really, I call it, interrogate their thought process, because you can't be with them 100% of the time. And they're doing things with following another nurse, and you cannot interrogate that process for what, well, why are you doing that then? Why did you do? But in VLE, we can, because they're independently going through it. It's all recorded. We can see and we can ask them, why are you doing this? What is your thought process there? So that really helps us to solidify and guarantee what's going on. And so what we've seen, and right now our data is we're collecting data. We're continuously collecting data. It's not really strong in connection between clinical reasoning and other learning modalities, but we can see a strong connection developing in our VLE process, and we can see it in simulation, and we can see it pieces and parts here and there, which is going to help us learn the nursing process, decrease sentinel events, be successful in the NCLEX exam. And I have one of my students, she joined us just a moment ago. Taylor, I'm gonna call on her and ask her to unmute. And Christine is here as well, two students from the San Diego ELM program. I just wanted to give them a chance to tell you what their thoughts are on how VLE helped them develop clinical reasoning and nursing process. So either one of you, go ahead.
I can jump in. My name's Taylor. I'm a third semester at the San Diego campus. Just listening to you guys right now, it's exactly what Professor Reyes was saying about clinical reasoning. I think a lot of what I struggled with the first and second semester was just like the answer to a lot of things was educate the patient on this, or know the signs and symptoms of this. But I'm like, so what is the education? What are the signs and symptoms? So I think going through iHuman, a lot of it is you have to give exact examples of what these things are. And so I'm like, okay, so now that's what I'm supposed to be doing. And I think it's so helpful just connecting all the dots instead of just knowing what I should be doing. Now I have the answers to do what I should be doing, I guess. But yeah, that's what I have to say about that. I can answer any questions if you guys didn't understand what I just said, but
If I could add to that, this is Christine, and I'm also a third-year student. And I just want to say we've been through 3 sets of adjunct instructors. And I just want you to know, if you're an adjunct on this call, how very important you are, how your instruction with us makes such a difference. We have some instructors, when we come on and we debrief iHuman, we never know who's going to take the next question. So you're constantly on your toes, prepared. I envision it very much like how physicians debrief, and the instructors that are really good are bringing in real world examples, and it's very dynamic. It's very engaging. And for me personally, I didn't come from a science background. Taylor came in very knowledgeable and having a rich background. I came in cold. And so iHuman gave me a lot of confidence. It showed me the kind of questions that I needed to be asking. And I just want to reinforce that idea that I felt much more confident that sentinel events were not going to be happening because I had this training. The other thing I want to tell you is that concept map is a thing of beauty. I love them. I work with them. I'm a visual learner, and it really makes a difference. So my parting thought, if you are an adjunct, use this tool dynamically, because you are the most valuable part of this process. We can read books, but we get our richness from you. And I want you to know how much I appreciate you protecting our hours and investing in us.
Thank you, both of you. So being in 3rd semester for Elm, just so you guys, that those of you who don't work in Elm, they're in OB and PEDS right now. And it's been very challenging for them because they have had hours here, there, and all over the place. They're not in a standard group every day. They're kind of all over the place. So being able to use VLE to fill in those gaps and to help them with their learning has been a big game changer for them in terms of keeping them solid moving forward. Does anybody have any questions for Christine or Taylor? I just asked them to join us briefly to give their thoughts and answer any questions if you guys have any.
Jenna, I have a question. Are you using the term sentinel event in a peculiar kind of way that is different from what we might be using it in the hospital, or is it the same definition?
It's the same definition. The literature really looks at a sentinel event after graduation, and basically, so one of our platforms that we're using, the NOVEX, that platform was actually not designed initially for nursing students. It was designed for new grad program, and so in that new grad program, that was one of the metrics they looked at, was if there was a decrease in sentinel events in that first year after using it, and there was. And so now that we're using it with students, they're finding that impact 1 year after graduation is still there, even when it's used in students versus new grads. I don't know if that answers the question.
Yeah, and Elaine, we're going to get into that. Mario's going to talk about the NOVEX program and the modality of how what they look for, because it was designed a little bit differently, a little bit more independently. The sentinel event is really things that shouldn't happen.
Thank you.
It's the bad things that shouldn't happen.
Yeah.
And NOVEX identifies those. If a student, as they're going through the case, does something, it lets them know that this is a sentinel event.
Thank you.
It tells them that this is something that should not have happened.
Yeah, so it could be like a med error. It could be, just think of like, cutting the wrong limb off. Like those are the sentinel events that it's helping prevent.
Are there any other questions for Christine or Taylor? Because I didn't tell them to set aside their whole evening, so I want to respect their time. But if anybody wants to talk to them, any of the faculty, hang out for a couple more minutes, guys, because we're going to talk about a couple of little more other things that I think you might find interesting. So the conceptual framework and the science behind VLE and the virtual simulation. There's a lot of, and I think it was Vicki who said, evidence is showing the effectiveness in learning. And when we're starting to look at our evidence-based practice and the literature, we're seeing that there is effectiveness in virtual learning, effectiveness in simulation in general, because you can control the scenario, you can control what happens, and every student is going to have exposure to these events and what's happening with that case. But there's even more emerging evidence showing that it might even be more effective than clinical hours, bedside, direct patient care hours, because we can have so much control. And because we have, if you have a really robust program with debriefing, pre-briefing, and really interrogating that thought process. So there's a lot of evidence emerging about the effect on development of clinical reasoning, improvement in high stakes testing, following the sim pedagogy. And then the second piece of this is the Anaxel standards, which is who sets our standards for simulation and establishing our best practices for simulation. And because it's kind of emerging and new, Anaxel is really working on making sure that we're matching, we're doing the same things in VLE and in virtual simulation as we would in hands-on simulation, as we would in clinical setting. So really treating it the same way in terms of a learning process. So Benner's novice to expert model is one of the overriding models, and most of us are familiar with it. But if you're not, I want to give you a brief overview. Basically, you start out a novice and you move towards expert along a continuum. And pretty much all we do in education and any really nursing, this is very nursing specific, but is to move our students along that continuum towards expert. We're always trying to move them along that continuum. And so NOVEX was built with Patricia Benner and big part of it. And so it's based off of her learning model, the NOVEX to expert, and that's why it's called NOVX. Right? Makes sense. The other one is constructivist learning theory, is that constructing new knowledge requires that you engage in the content. And so requiring the student to engage in the content creates new knowledge. So what we're doing in simulation in general, but especially in virtual sim, is constructing new knowledge using these theories as our framework and our background. So, and that's a big part of the concept mapping pedagogy, the knowledge of concept mapping, really based on constructive learning theory. And it has been shown across multiple different professions to have an improvement in clinical reasoning, critical thinking development because of the process. Now, concept maps look different based on what you're learning. So there's all kinds of concept maps that we can do. But what we're using for concept mapping for in our VLE process is as a formative learning tool, workbook, assessment. We're forming new knowledge while they're working through it. So part of the process is we ask them to approach it on their own. And then when we're in our debrief, we work through the concept map together as a group. And I think that's where Christine was kind of going about. You never know who she's going to call on, and we never know. We're doing it in our small clinical groups. So we're all engaged in that learning, following that constructive learning model. The concept map we're using is very specific to the nursing process, the assessment, the diagnosis, the interventions, the planning, with a couple of little key pieces in there as well. So here's a question, and this is along those same lines as Chris was talking about. In a typical semester, and Taylor and Christine, feel free to answer this. Which of the following do your students have the opportunity to care for? How many of these do your students actually have the opportunity to care for in a normal clinical setting? What's interesting, see, yeah, maybe a hypertensive crisis. And we did do some of these cases in the hands-on simulation. When we were doing hands-on simulation, we did do some of these cases to cover this content. With the VLE, we have the opportunity to cover so much more. This is just a handful of the cases that we get to cover. When we do NOVEX, they'll get 6 or 7 stroke patients. So they get stroke patients in multiple different ways, multiple different presentations, multiple different types. iHuman, and I'm going to talk about iHuman a little bit right now, is very specific in how you have to walk through it, whereas NAVEX is much more independent and independent learning and thinking. So what we have over here, 2, 3, maybe 4. Taylor said she had H one time, a hypertensive crisis one time, acute asthma. The OB nurses, how about placental abruption? Right? Maybe, never. Like, the thing about this is really great is that iHuman is, and I'm gonna go back to this, iHuman is associated with the Kaplan Test Prep, their sister companies. And so they have a really good grasp of what's on the NCLEX, and they matched their cases really closely to what the students are going to be tested on in the NCLEX. So these are all types of patients that you would see in NCLEX, but they're not types of patients that you would necessarily get at your clinical setting, like ditch toxicity, unless, or an acute DKA, that they don't know how it's going to present in different ways. They know like maybe what the textbook told them, and that's about it. So that's one of the really great things. One of the things, and Jennifer's saying that she loves it. Thank you, Jennifer. One of the things that we wanted to talk about is the faculty-led debriefing. And this is very similar. The debriefing is very similar to like a post-conference. The only difference is all of the students had the same patient. So all of the students can say, and I love it when 1 or 2 students says, oh, you didn't ask them about that? I did, and this is the answer I got. And then that student's like, oh, maybe we should, that's such valuable, rich learning from each other, not just the faculty talking to them the whole time. So really helping them to operationalize the nursing process of how you assess and what that means. If you don't get a good assessment, you don't necessarily get to have that data to work with to make a plan for your interventions because you didn't do a thorough assessment. You didn't ask that question. And also, we really spend a lot of time working on our nursing diagnoses in the iHuman product. Spend a lot of time with the concept map working through the nursing diagnosis so that they have a really strong, firm grasp of that. And thinking about when they're in the NAVEX product, they look a lot more about their skills of what they're doing and why they're doing it, making that connection in a cognitive way. So the iHuman process, for those of you who are not working on it, and I see Shatona, who's one of our faculty, so I know she's working in it. But those of you who are not, they have a pre-sim set of questions. It's pretty straightforward. We ask them to answer those questions before they start their sim. It's what we as experienced nurses do when we hear a report. Like, what am I worried about for this patient? What are my top 3 things I want to think about? What medications do I anticipate? What do I already know about this disease process? What things do I need to make sure I assess? Without having them do this on their own, they may not know that that's what they need to do. So we're setting them up to start doing that when they're in clinicals already. And then they have the time to complete their assigned case. We worked really hard to align it with the curriculum, and that was part of Lori's work and the chair's work, aligning it with curriculum. There's some times where we cover content that they haven't covered in lecture yet, but we're really working on that. We're asking our students to achieve a 60% based on iHuman's process of how they grade the case. This is what Christine and Taylor, early on, you probably challenged a little bit, but now when you do an iHuman case, what is your average and score averages? Now that you know what you're doing.
I'm sure Taylor's are higher than mine, but at least I would say 80%.
I agree. Yeah, about 80.
Yeah, so the first couple of weeks, it's a challenge, but after you get to doing it a little bit, and so what they're scored on is their completeness of evaluating the electronic health record, their completeness of their physical assessment, their identification of their priorities, prioritizing the care, and then in analyzing that. So they first have to find out what the problems were, and then they have to identify the prioritization. And that's where most students struggle. Most students struggle the most with the prioritization part of it. And there's a couple of questions that iHuman asks them and walks them through. So the 60% benchmark we felt was like a pretty reasonable benchmark, especially even for our newbies. And then we have them do a 2-hour debrief that is faculty led. And that's what Shatona, myself, Chris, Mario, all of us are doing some of those debriefs. I don't know if there's any other of the VLE faculty here, but I think there probably are. That really walks them through. Well, tell me, give me a report on this patient. Tell me about this patient. What were the things we wanted to do for this patient? What are those nursing diagnoses? What's your education plan? How are you going to assess this patient? How are you going to assess their knowledge? What is our priority for them? And we talk a little bit about motivational interviewing. We talk a little bit about the pathophysiology of the disease process, the things that they need to know to be able to safely take care of this patient in the future. And then they have these formative learning worksheets. Now I'm calling them worksheets now, when in the past we called them documents, but I think worksheets is a better term for it, more realistic term. And one of those is the concept map. The other one is a formal education plan. One of them, it's called an SBAR form, but it's not really an SBAR form. It's really a report form with some critical thinking questions. And the pre-sim questions, they have to turn that in. They turn those in for every case. So that's how we're really bringing it all back together. Christine or Taylor, do you have any comments you want to say about those documents? No. All the students think the education plan is really long. They all think that, pretty standard across the board. But I think it's really valuable. I think it's really important that we teach our students from the get-go that you need to think about how you're going to educate your patient. So here's just an example, a quick example of the pre-sim questions. Same things, like I said, that we would talk about if we would think about as experienced nurses when we get report. This is an example of the iHuman modality. When they first sign in, they get the EHR here and they need to click through all that and click on this questions, multiple choice questions. One of the really cool things about it, iHuman is very structured. It's very structured, so they can't move forward until they've done this. They have to do this before they can move forward. Then they go to the history section, and that's where they can ask questions. There's a lot of available questions, and a lot of students struggle with that at first because there's like 300 available questions, and they have to kind of weed through which ones are the priority questions for this patient. Then they go to the physical, analyze, actions, nurse's notes, and then the summary. But once they've done that, they can sign back in and they can get feedback from the expert. And they can see what they got right, what they got wrong. And there's feedback right there with links to the content right there telling them, so they can use this as a resource to learn the knowledge they didn't know. And then this is the summary of the patient that they would see. So it gives them a summary at the end, and I love this. It links them to the QSIN competencies, and it tells the student. They also talk about the medications, and they give them all the information about the medications and other things that are going on with that in the iHuman iHuman case. So they really get to move forward and get all that, bring it all back together. And I think our next slide goes into NAVEX. So this is just an example of the iHuman. And I'm going to turn it over to Mario for NAVEX. Now, Christine and Taylor, have you worked with NAVEX?
We haven't, and I'm going to sign off if that's okay, Professor. And again, I just wanted to say thank you to our adjuncts. I'm sure if people put the years of experience in the chat, there would be hundreds and hundreds of years in this meeting. And I just want to say how much we all appreciate you. Thank you for all you do for us.
Thank you, Christine. And thank you also, Taylor.
Do you want me to stay or?
Nope, not unless you want to. You can if you'd like to learn about NAVEX, absolutely.
I'd love to. All right, thank you guys, I appreciate it.
Thank you, Taylor. So I'm gonna turn it over to Mario. I'm gonna mute myself, but I'll keep doing the slides for you, Mario.
No worries. Good evening, everybody. First and foremost, I missed you all. Really, when it comes to virtual simulation, I'm going to admit this in front of everyone here, and Renee knows this. when I used to entertain that idea of virtual simulation, the first thing that came to mind was, listen, this is a glorified case study, okay? And so, you know, Renee, Dr. Poza saw that I was kicking and scratching and just not gonna have anything to do with virtual simulation. But lo and behold, over 6, 7, 8 months ago, we got T-boned by this pandemic and we had no choice. And what a humbling experience. But as I told, you know, Renee and the rest of the VLE team, or at least some of them, I've actually fallen in love with this type of learning. And, you know, it's something that, you know, I really didn't think was gonna happen to me, but it did. I fell in love with her, okay? Her name is Navix. And so that said, friends, as was mentioned earlier, Jenna said that Navix is the baby of a partnership between Health Impacts California Simulation Alliance and Dr. Patricia Benner. And they came together to provide this clinical replacement simulation platform to a number of folks. And so what is different between Navix and iHuman? Well, friends, I'm going to tell you, when it comes to Navix, there's a lot of things that would, you know, set the two apart. Number one, the time invested in Navix is in the actual simulation platform is not like iHuman, because when I was engaged in iHuman, I could find myself there for as long as maybe 3-4 hours. Okay. Now, when it came to Navix, I could find myself in Navix for maybe up to maybe about half an hour. And if I went through it thoroughly, right, and I was pretty adept with all the different buttons and, you know, all the different things that we could, you know, take advantage of, then I could probably bring that 30 minutes probably down to about 15, 20 minutes. But what makes it stand out is this. Number one, okay, if I'm just gonna cut to the chase, typically in face-to-face simulation, what our students would do is they would go into the room and they would introduce themselves, you know, they do the safety practices like hand hygiene, hand washing, put on gloves, and, you know, go up to the patient, look at their identifiers, and then ask them what they were doing in the room, okay, or in the hospital. And so they would do this data collection approach. And after they felt that everything was, you know, maxed out, they would stop their assessment piece and they would collaborate with the physician, which was either Jenna, myself, or any of our adjunct faculty. Now, the deal is this, once they would communicate to the quote unquote physician, we would have a set of orders that we would read to them or maybe give them a copy of, and then they would go about, you know, executing these interventions. Well, with Navix, friends, this is an absolute change in paradigm, literally, because we don't give them doctor's orders, okay? And so if you look at number one, it says complete evidence-based practice lessons. So the pre-case activity that these students need to do is they literally need to go in and read these lessons. Now, what are these lessons comprised of? Well, I will tell you, it's a very, I would say, it's a very concise, effective, right, presentation of knowledge that would guide our students through these cases. And, you know, it's pretty obvious if you look through the patterns that our students generate, which we refer to as click streams, to identify students who haven't really read the lesson, because sometimes we'll have students that won't read the lesson and just go in and just click, 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 and try to figure out if they could pass the first time around, only to find out that they wouldn't pass if they didn't read the lesson. Now, there's another way to pass this, right? But it's the wrong way to pass it. And it's essentially what they would do is they would go in, fail, right? And after failing, it would give them a list of steps that they needed to do, right, to actually pass the case. Well, friends, I would say this instrument that we call Navix, right, is a very, what do you call it, potent instrument if you know how to manage it. And so I'm looking at the slide, the need to know. Number one, it prescribes that we have to read the lessons, okay? And number two, it says cases interventions are based on the latest evidence-based practice guidelines. Remember to address the urgent and highest priority care when you're dealing with the patients. And so just going back, a huge premise to dealing with this particular software and taking advantage of its, I would say, capacity is to go back, read the lesson, right? Then go into the case. And one other thing beyond that is to do the case with the lesson open on a different tab. And so friends, you will find that when your students go into NAVIX, you will see that they will read the chief complaint and they will stay there for a good 10 minutes. Okay, now, if you read the chief complaint, you can browse through it like in a minute, but you'll notice that they're there for 5 minutes. And what happens is this, because of that time element, we suspect that after they read the chief complaint, they go back to the lessons and they're trying to read up on the stuff that they had read before. And so this lesson plan or this lesson that they have before them is somewhat of a guideline for them to navigate through this scenario. Now, as they're going through the scenario, right, this says NAVIX demo, and when they first get into NAVIX, friends, we give them a little session where they look for the oxygen, where they look for the IV pump, they look for patient allergies and what have you. Let's go on to the next slide, Jenna. All right, this is the pre-case. Now, the lesson kind of looks like this, right? And what's cool about these lessons is they're not bland. Friends, we have books, textbooks that we read through. And, sometimes I have found myself, being put to sleep because of the way they've been put together. But if you look at these lessons, guys, whoever put these lessons together, they were highly intelligent and strategic. And so when you read these lessons, they're really enticing, okay? And what's important about it, and I don't know if any of you guys know about this, it's the blue and the green. When you look for the blue and green boxes, friends, there you will find the doctor's orders that we didn't give to the students. But the students don't know this. They have to actually read it, all right? Now, if we can move on to the next slide. Okay, the lessons are comprised over here of the different bullets, clinical relevance, patho, risk factors, and so on and so forth. But you'll notice the cluster of cases that exist. You'll notice here on the left side, you've got Babler, Boehner, Butler, and Gabelli. And above them, you have two lessons, one that deals with pneumonia and one that deals with COPD. But as these students run through these cases, we're not going to tell them that Babler is a COPD patient. We won't tell them that Boehner is a pneumonia patient, and so on and so forth. But as they read through the cases, they're going to identify that, hey, this is a pneumonia patient. So I'm going to open up my pneumonia lesson, okay? All right. Now, I don't know if there's anything after this, guys. What's different? It's simple, guys. That box over there, which says HCP orders, it says the healthcare provider has ordered all the appropriate medical interventions. Nurses must always have a medical order prior to administering a medical intervention. Okay, now friends, unless the student has read the lesson, it's not going to happen. Okay, they're not going to have any direction. Maybe something that they ran into in the didactic setting, but it's not going to happen. Okay, now let me just throw this out there. How can NAVIX help our students? Well, you've got, in the previous slide, we had Mr. Boehner, Mr. Babler, and so on and so forth. These cases are very similar. And the more they do a case and the more they do similar cases, the more they get to implement all the things that they read up on these lessons. And so the bottom line is practice makes perfect. Now, how is this different, okay, from actual patient, direct patient care? Well, I want to pull out a piece of information that I ran into most recently. And this is a study that was done in 2014 by a doctor. His name is Dr. Biasiotto. And he did this at the University of Chicago. And some of you have heard this. What he did is he took a group of basketball players and he divided them into three groups. One group, he had them practice shooting free throws for 1 hour, okay? Another group, he had them sit on the free throw line, right? And visualize themselves making free throws. And that third group, he had them do nothing at all, okay? So after a month, what he did is he tested these groups doing their free throws. And the first group, they improved by 24%. Okay, this is the one who were doing 1 hour practices of free throws. But this second group, which pertains to us, right? That group that sat on the free throw line and visualized how they were making free throws, they improved by 23%. Just going over the concept, The third group, as expected, there was no improvement. But the bottom line is this: when it comes to NAVIX, practice makes perfect. Practice makes perfect. We ask the students to go into the room and proceed as if they were in a real room. So when I go out with my students and we go over a case, I literally have them say, okay, so you're walking into this patient's room, what's happening? So I have my student knocking on the door and they say, hey, my name is Nurse Mac. I'm here to take care of you today. And while I'm introducing myself, I'm washing my hands and I'm putting on my gloves. Okay, well then I'll ask them, so after that, what do you do? And so they say, well, I go to my patient and make sure it's the right patient. So I'll check for his identifiers. I'll ask him to state his name and state his birth date. And so same thing with NAVIX. What we want to see on NAVIX is everything that they would do in an actual patient environment. We want them to reflect on this patient care environment. I have told our students time and time again, you can pass this case, right? But still fail it. We have one particular patient, and I'll just make this as an example. The only intervention that needs to be done is to give him Lasix. Okay, this is a gentleman who is 58 years old, right? Who is in the midst of a crisis where he's got CHF and he's been drinking a ton of water. He's been eating all the wrong things, a high sodium diet. And bottom line is, in 2 weeks, he's gained 30 pounds. The only thing that we have to do is give Lasix. Now, a student who's gaming this literally can go in, open the case, look for Lasix, hit it, finish the case, and pass. But friends, that is not passing. What we're looking for is the nursing process. Did you do your assessment, right? Did you do your interventions based on the orders that you believe are correct? Did you reevaluate? And even beyond that, as Elaine said earlier, can they address sentinel events or these never events? Yes, what I tell my students is this: after you've addressed the urgent and high priority needs of your patient, then I want you to address the never events that possibly could happen. Give me 3 to 4 things that you could do to make sure that your patient will not get hurt while they're here in the environment. Okay. The next thing that I ask them is this: most definitely, our patients will come in with knowledge deficits. So what can you do in terms of education to actually address these deficits? So we ask our students to do at least 3 or 4 patient education sessions. And so they will say, well, you know what? I'm going to talk to my patient about his diet. I'm going to talk about smoking cessation. I'm going to talk about making sure that while he's here in the hospital, that he's going to be using his incentives barometer, and so on and so forth. Now, because we are APU, we also bring it up a different notch, okay? We also ask our students, all right, in light of APU and God first, how would you support your patient spiritually? How would you support your patient socially and emotionally? And so we also try to elicit this from our students. But friends, NAVIX, we're just in our second semester of using this tool. I feel like, okay, and you may laugh at this, friends, but I feel like we've been given this musical instrument. And last semester, we only learned how to play 3 notes, okay? But by this second semester, I feel like we're able to play at least a sonata or a minuet. Not perfectly, but friends, it's happening. It's happening. Okay, now I know I'm looking at some of the names here. I know I've been working with some of you with NAVIX. But friends, with this team that I'm hooked up with, these guys are amazing. If there were a group of super friends, super academic friends, these are the folks that I'm so appreciative of. But I don't know if there's anything else after this. Jenna, is there something else after this? Okay.
So one thing I want to make sure, and I was kind of surprised by this. This is one of the things that's in NAVIX, which I think Mario talked about it a lot, but when they go to give medications, they have to choose which medication. They have to say, I want to give a cardiac drug. And then all the cardiac drugs come up, and then they have to choose which cardiac drug. I want to give Lasix. Do I want to give spironolactone? Do I want to give hydrochlorothiazide? Do I want to give digoxin? What do I want to give? And that's where one of the really beautiful things is, if they just click on something, it'll be like, nope, try again, start over. So they
Here's another
have to
thing too.
know their stuff. They have to think independently without, it's not a physician's order to give spironolactone. If you have to know which one should be the right medication for this patient.
Well, here's another thing too, guys. We all know that when we're in the patient care environment, before I give that medication, I got to do my rights of medication administration. So friends, it's not enough that they give Lasix or spironolactone or lisinopril or what have you. They have to go through the rights, and afterwards, right? If you gave this medication, did it work? Okay, did it work? You've got to reevaluate. So for me, this is an instrument that if we take it to the max, this is going to benefit our students. We know that there have been studies that have used Navix in as a supplement to these NCLEX preparation platforms, and they have found that when these students, not our students, but when these students involved in the study were using Navix, majority of them all passed NCLEX the very first time. Okay, this was massive. This was massive, and so yeah, this is Navix, friends. We're still in the midst of developing our implementation process, but guys, with this team, by the next 2 semesters, I think we're going to iron out all the wrinkles, and you're going to see a very beautiful and efficient engine running in front of you.
Do you want to talk? Well, I'll just put the student feedback up here, but some of them I think are just really stellar. It's like, I really feel like I'm my own nurse. I'm an independent nurse working on my own. There isn't a part of the process I don't like. I wouldn't miss it for the world, and helped me so much to know how my skills improve. I really think that knowing what the students, how they perceive the products is really valuable for us. And then the next piece is we're just going to do question and answer, and we'll all kind of round table on questions and answers. And then that's our last slide.
And I would say go ahead and just unmute yourself. And if we have too many people trying to compete for questions, then I'll do raise hand in the chat. But otherwise, just unmute yourself and shoot.
I have a question. This is Vicki Young. My question is, I really have a hard time. I teach clinical, and what I have a hard time is really trying to understand what nursing, how are we teaching the nursing process, or what clinical reasoning model we use in our department, because I don't think we use the same terminology, or I don't know what the terminology is, because the paper, our clinical worksheet that we use now talks about Q clustering. You know, they do their focus assessment, talk about what the clinical significance is, but when we get to the part of Q clustering, they don't know what Q clustering is or data clustering. And I know that in these programs, that's one part that they're doing, but how are we teaching that and making sure we're using the same language, or that they recognize that that's what needs to be done?
I don't know that I have a great answer for that, to be honest, but what I can say is that we did have a faculty meeting on Friday, and there's going to be some structure around the virtual learning experience. So there's a subcommittee that's now being formed for experiential learning. That's going to include a huge piece of virtual learning. And our goal is to make sure that we are in alignment with all of the different programs, whether it be, you know, graduate or undergraduate, and then have all of the work that we're doing blessed by the curriculum committee. So I think right now we're kind of just, it's all starting out. So I don't know, I have a great answer for that, but we're looking to really make sure that we align everything that we do, whether it's online, in person, you know, and regardless of the department. So like I said, I can't say that we're not teaching the word that you just said, because I don't even know what it is. We're not teaching to that, but it'll definitely be something that we need to look into as we begin to really streamline the virtual learning experience and then the experiential learning with the rest of the curriculum.
But when I went back and looked at our fundamental book, they do talk about data clustering and putting, different data together. And I just don't really think students understand the concept of the main process. I don't know. I mean, because I teach third semester, and it's like they still don't understand what I'm talking about the process.
So for iHuman, iHuman that's a big part of the concept map. That's a big part of what the concept map is. It's the pathophysiology, signs and symptoms, and then making your nursing process, nursing diagnosis. I don't know that we called it Q clustering or data clustering, but now I want to go look in the fundamental book.
Yeah.
I think we're talking the same thing, but that's really what it is. I think is what we're talking about. We're maybe just using different names for it.
Yeah, well, when you say signs and symptoms, that's just for that one thing. But when they don't seem to know, they'll give me one cue and think it's a cluster.
Right.
And it's like, for example, they can have, well, because we have oncology and they have nausea and vomiting or diarrhea. And so they get dehydrated. But what are the signs and symptoms of dehydration? Electrolyte imbalances, what are, those are the clusters. Are they even eating? How is it affecting those fundamental things? Are they eating, drinking, walking,
well, especially early on, our students always want to use the monitor as their sign and symptom, right, Vicki? Like their electrolytes are off. Well, I think that's a big part of telling them, and this is why I always tell them, you need to use your God-given gifts first, okay? Your eyeballs, your hands, your sense of smell. Like there's a lot of signs and symptoms to pick up before you see the lab value. Before you have that dehydration, you could look at their lips and their lips look cracked. You can look at their skin and they're right. So all of those assessments are really, and Elizabeth shared with us. So that makes total sense. So, but I think that's, and I didn't share the concept map here, but I can share it later on. And I think you'll see that that's what one of the big things of the concept map is. Yeah,
I did do iHuman last spring, so I'm familiar with it.
Yeah.
But it's just trying to translate into the real setting.
Yeah.
And that normal data is significant. Sorry, I don't mean to talk a lot, but that's just the one thing that really concerns me or bothers me, trying to figure it out, what they've already, trying to build on one another. I think it's so important.
Yeah. Well, I think it's a challenge for all of us all along. One of the, all throughout any nursing program, no matter what type of teaching and learning you're doing, is, are we building on what the other people did before us? What do they already know? That's a challenge for everybody, right?
And they act like they never heard it before when they have.
One of our challenges is that we all use a different language for sometimes the same things. And I think one of the exciting things about a dialogue like this and a presentation and having 3 different modalities of looking at patient care is that we can also start using some of a more common language and more common terminology across the different levels and across different faculty, adjunct and full-time faculty. And I think the students will really appreciate that as well, because they sometimes get confused themselves when we use one terminology and somebody else uses another, and they don't know enough to know how to translate that. And so I think this is very exciting. Great presentations, by the way, for all of you.
Mm-hmm.
I would piggyback on that by just saying that I think the whole, it would be good for us as a school to have some definitions around the difference between critical thinking and clinical reasoning.
Oh.
And the language that now is in the literature around clinical reasoning, so that we all are using that very, very purposefully and knowledgeably in terms of what we mean by that. It means using critical information in a clinical setting and sorting priority cues to make decisions.
Along that line is also in having a robust faculty training on that to keep us all on the same page, all on the same plan, and what textbook, what websites, what things are we using so that we're all using and pushing our students back to the same resources. Because, you know, like I said in my literature review, depends on who you ask, the definition of critical thinking. There's different definitions. So using the same discussion, the same terminology across the board, across all our programs would be super valuable. I think, Lynn, is it Lynn? Linda?
Yes, Linda Schutz.
Yeah, had a comment.
Yes, I work in our psych mental health nurse practitioner program with Professor James Adams. And I don't know if there's any other clinical adjunct from that program, whether they're in IMPA or elsewhere. But I help with OSCEs too. And what I think we need to learn to do is to teach about subtle changes and observation. And I love Benner's theory book her book on novice to expert. And I read it a long time ago. And it's kind of been a guide for me in working with students. And but I think we need to connect it too with the virtual learning. In my work experience, on a psych unit, I've walked in as a nurse practitioner and seen someone with altered mental status, and it's what's going on as I made my rounds, and what's the blood sugar? You know, we got to start teaching, put the two together as well. But we divide the body and the brain, and we got to encourage to be holistic. And like an OB patient gets put on the locked unit. Well, buddy, that's a challenge. And so we gotta, I feel as my job in my role as a clinical adjunct supporting my students is, okay, don't forget, there's a body there, there's a baby there. And you got to watch the mom real close psychiatrically, but you also have to take care of that body and that baby. There's so much in there that we could use both modalities for our students. And I would rather see them learn this, recognizing DKA, abruptional placenta, and, you know, alcohol intoxication, and what's their signs and symptoms, and put it together with, you know, other things in a learning situation like this as they go through the program. So this is exciting.
Thank you, Linda, right?
Yeah.
Yeah, I agree. I think we need to encourage holistic view of our patients and a holism. And some of the students, they get, like I said, they get a little bit of pushback on the education plan and why do we have to work on that? And I'm like, you know, because you're not just treating them with a medication and walking out the door. You have to treat the whole patient, and that a big part of that is your education. Meredith has her hand raised. Somebody let me know. I didn't see it, but Meredith, you have a question?
I do, thank you. I have sort of more of a technical question. So I thought that the students that had shared their perspective with us had mentioned that they have not seen Navex yet. And I apologize if this was covered and I missed it. Are we uniformly using iPatient and Navex in certain semesters with certain courses? What's the sort of
so we
layout?
Sort of have a course map, and they're with the ELM program, and you work with ELM too, so you probably know. So they essentially have 5 semesters, and they kind of bounce back and forth between iHuman and NAVEX, but they get NAVEX in their 4th and 5th semesters because it's not has a strong, they also got it this in 2nd semester. Some of those students got it, but it doesn't have, they have to know a lot to be able to successfully manage it. And so it's not really great for them early on because they don't know that they don't know. So,
okay, and then I have a follow-up question now that I understand that. Is that true for traditionally educated students, like in the traditional BSN or the other programs?
They have it in the last semesters as well. And so
in traditional BSN?
Yes, in the traditional undergrad, they'll have it in their critical care rotation, and they'll also have it in their residency, which is the last 8 weeks. And so
Okay.
yes, it's I'm not going to say it's a carbon copy of each other, but there's that I would say there's that pattern that it runs by when it comes to ELM or the traditional undergrad or the 2+2 as well as the LVN to BSN. So there's a degree of consistency with that.
So that helps me because I'm wondering. Well, so first of all, just some really quick personal history. So I used to do critical care clinical instruction in the hospital, and I'm now doing critical care didactic. I also work as an FNP. And when I did clinical instruction, I used another source of virtual sim, particularly for sepsis and some other things. And so I'm excited to see this getting incorporated sort of more formally because like you pointed out in your presentation, some students aren't going to see it. Like it depends on what hospital they're at. It depends on what floor they're at. It depends on, so many other variables that we don't have control over. So I was using it for some things like that. So I'm wondering, and this is probably my bad because this is my first semester into didactic, what the correlation between what my didactic schedule is and what the NAVEX schedule is. And I'm excited to make that really relevant. How are you deciding what cases they do?
So how we aligned it initially, Mario, do you want to answer? Go ahead. You go ahead.
No.
We both started talking.
Yeah, we had the input of our chairs when it came to deciding as to how to align the cases based on what was being scheduled in the didactic setting. So it's not one of those deals that we're just going to randomly throw these scenarios out. It's kind of like the traditional face-to-face simulation where when we set up our simulations, we made sure that before we gave the DKA scenario that it was talked about in the didactic setting. So it's not one of those deals where it's going to happen randomly. No, everything was strategically placed.
Okay, so with iHuman, there's a debrief session, right? That's strategic, but with NAVEX, there's not. It's independent, right?
So it depends on where you're at. If let's say you're in the 573 portion of the curriculum in ELM, then we will have the students do a number of cases, and based on those cases, what we would do is we would do that final evaluation. Now with 588, right, they would have, for example, they would have 3 debriefing sessions all throughout the semester. And before each debriefing session, what would happen is they would be required to finish a set of cases, okay? And now, once they finish a set of cases, then we meet with them for a 2-hour bracket of time, and we talk about a number of those cases. And so as an evaluator, what I do is I look to the click streams, and I look for those cases that are most problematic for our students. And based on the top 3 or 4, that's what we're going to be talking about in terms of debriefing.
Cool. I'm going to send you some emails.
Yeah.
So
More personal.
this is exciting. A really wonderful turnout as well. I'm going to throw out a couple things. First of all, just physiologically, there is the evaluation, the infamous evaluation in the chat that you should be able to access to get your CEUs. And I really, we are closing right now. And I know Dr. Poza did mention she's looking for VLE people to add to her team. But what I'd like to do is, before we go off, just say a special thanks to the infamous support person, Shayna Chavez, who I know that all of you keeps all of you adjuncts connected and answers all your questions and all that. And Dr. Gaynor, who works to get CEUs done for you, who's here as well. Anybody else that I should thank? I mean, all of you we're thankful for, but I don't want to miss anybody. But anyways, with that being said, I am going to officially close the program now in terms of the content, but I am going to leave the link open, and I think some of the VLE faculty will probably be able to stay on and maybe field some further questions. And again, we're here. What else are we doing, right? So I don't know if anybody else has some parting words, but on behalf of the School of Nursing, number one, thank you for being a part of the next generation of nurses. And I look forward, as I mentioned in the chat, hearing further from you about some events that we can hold for you in spring semester that can really serve your needs as adjunct faculty. So thanks again. And again, I'm not leaving, but I know that some of you may do so. Thank you.
Thank you for offering this. It was great.
Yes.